Dear audience, I would like to present my PhD thesis, which is the use of novel MRI techniques in the diagnosis of chondrogenic bone tumors. My name is Dr. György Gulácsi. I work at the Medical Imaging Center, Semmelweis University, as a consultant radiologist, and I'm also a full-time PhD student at the Translational Center in the Semmelweis University. My vision is to provide state-of-the-art diagnostic care for patients with bone and soft tissue tumors. And my mission is to determine the optimal imaging methods, imaging algorithms of chondrogenic bone tumors that can eventuate a higher clinical decision-making efficacy. So I have two specific goals. I have two specific projects that are right now ongoing. The first one is investigating the diagnostic accuracy of advanced MRI techniques in patients with cartilage-forming bone tumors. And the other is a clinical trial of this in our own institution. And I would like to present the first one, which is a systematic review and a meta-analysis. So I would like to tell a little background about these cartilage-forming bone tumors. These tumors are actually quite prevalent, and most of them are benign. But their malignant counterpart, chondrosarcoma, accounts 25% of all primary malignant bone tumors, and they are the second most common primary malignant bone tumors behind osteosarcoma. But the annual incidence is quite low, as you can see. The clinical problem is that accurate grading of these cartilaginous tumors are needed because the appropriate therapy differs greatly among the different types of cartilage-forming bone tumors, as you can see. And the problem is that it is not so easy to do. It needs a clinical, a pathological, and radiological input in the diagnosis, and it is also a challenging task because the imaging features and the pathological features are not so straightforward. The other problem in the imaging department is that the conventional MRI techniques that are nowadays used are not accurate enough, and that's why new techniques were started to be used in sarcoma imaging, namely DC MRI, which is perfusion imaging, DWI, which is the diffusion-weighted imaging, that is about the diffusibility of water molecules inside the tumor. And the third, and I think the most promising technique, is radiomics, which is a post-processing method that is about extracting a large number of features in medical images by data processing algorithms. And our clinical question is that what is the diagnostic accuracy of these new techniques compared to the conventional ones? And as you can see, because it's a diagnostical meta-analysis, we use the PERD model. Our patient population is patients with verified chondroid tumors, either with imaging or histology. The index tests are the new techniques, DC, DWI, and radiomics, and the reference test is, of course, the conventional MRI technique. And the diagnosis here is the cartilage-forming bone tumors, how they can separate these entities from each other. And our hypothesis is that these new techniques can perform better compared to the conventional ones. And of course, the clinical implication is better preoperative clinical radiological decision-making in the treatment of these tumors. So here you can see that we searched in 4 databases. You can see the search keys. And we found only 12 eligible articles when we do the selection. And actually 9 of them were about radiomics, and only 3 of them were about the other 2 methods. So we could make only quantitative analysis of the radiomics, and we can only use the DC and DWR for just to see the results, the preliminary results, because it is not very well documented, these methods in the literature. So the outcomes, Unfortunately, because we have very scarce data in this regard, we could only compare in the radiomic field the benign versus malignant comparison. We couldn't have enough data to compare the benign versus low grade and the low grade versus high grade malignant tumors. And as I mentioned earlier, we couldn't use outcomes from the DC and the DWI groups. So here you can see the sensitivity and specificity pool. We created 4 subgroups. You can see that we created a T1 weighted and a T2 weighted subgroups. We compared it with the expert analysis, so the radiologist's diagnosis. We compared it with the radiomics T1 and T2 results. And as you can see, the expert subgroup had very, very low sensitivity, unacceptable low sensitivity and specificity in differentiating between benign and malignant cartilage-forming bone tumors, and the radiomics performed much better compared to the expert. The other subgroup consists other sequences that were published, but it is not relevant to us right now in this regard. And here you can see the OUTS results, which you can see here, the T1 and T2 weighted images, the other. Here you can see that the confidence intervals are quite wide in the first 2 subgroups in T1, and only the PAN article had an acceptable confidence interval, but it was an overfitted model, so it wouldn't be good if we would test it in an external test database. So what are the strengths and limitations of this systematic review and meta-analysis? We use the rigorous method selection criteria and article inclusion-exclusion criteria, and we also added radiomics quality score. So we qualified the articles using quality score, but the limitations are the small sample size, the low quality of results reporting, and the partially overlapping patient population, unfortunately. And here you can see the conclusion that I mentioned earlier. It has insufficient number of articles, poor quality of radiomics analysis, and flow overall methodology. So we concluded our first project. We finalized the manuscript, and those are journal selections. And just a few words about my second topic, which is kind of like this topic of our own. We would like to see what we can see from the data from Semmelweis University. So actually we collected data from our own National Bone Tumor Registry, data between 2012 and 2022. We found 84 patients with histologically proven long bone chondroid tumor, and 55 of those patients have MRI in the PAC system of Semmelweis University, and these axial T1 and T2 sequences will be gathered for radiomics analysis. And just an interesting flowchart how the radiomics analysis is conducted. Here you can see that we are right now at the export phase of the MRIs from PACS. After that, we do the image post-processing. We extract those imaging features that I just mentioned, and after that, we will compare it with the expert diagnosis of two radiologists, and we will compare the sensitivity and specificity of this new radiomics model with our own diagnostic accuracy. And I would like to conclude it with a quote from Walter: "The more I read, the more I acquire, the more certain I am that I know nothing." Thank you very much for your attention.
Congratulations as well. I would like to ask, it's wonderful to see that you saw the uncertain results from the first project and you directly applied it in your second project. I'm very curious which data you will get. I just want to ask concerning this chondrosarcoma. You mentioned that the incidence is very low, but is there any change concerning this? Because it was based on very old article. So maybe if you also saw any change in the current data, I think it was from 95, this article. Is there any changes? We know that the incidence of cancers is growing generally. Thank you.
As far as I know, there is no major changes in the incidence of this kind of tumor. Basically, that's my answer for your question.
Congratulations. I liked your second project actually very much. Although there is no data still, but the first project, it was this project, it was very surprising that you processed or involved 84 patients or something like this, and only 50 were examined with MRI. So do you know anything about it, the reason why these 30 patients haven't been examined by MRI?
Yes, I know. It is only those patients who have MRI in our PAC system. There are patients who were examined in an external center, and it wasn't uploaded. It hasn't been uploaded to our PACS server. So we would like to contact those patients if they have some kind of MRI. Conducted in another center, and we would like to collect it.
These records is ongoing, actually.
Yes, it's ongoing. Thanks. It's ongoing.
Regarding to the second one, I have a question about the machine learning. You saw that after you're reprocessing the voxels, you are feeding the algorithm with clinical data as well. And I'm wondering what kind of clinical data are you feeding in that algorithm?
The algorithm is fed by the final diagnosis.
Just the diagnosis?
Yes.
Okay.
As far as I know.
I also would have one question, György. First of all, thank you very much for your presentation and congratulations on your progress. One general question about radiomics. How could one imagine it? Is this new technique, since it was very promising in your results, is it just a software update every radiologist could get for their current MRIs, or do we need to buy new hardware, new MRI techniques?
No, you don't need to buy new hardware. It's actually a post-processing technique. You need to have a model which is developed by a research group or by a company, and you have to buy that program if you want to use it, or develop your own model if you have experts at your department. Yeah.